Susan Miller, and I am the Interim Vice President of the Frederick Meyer and Heart Vascular Institute located at the Fred and Lena Meyer Heart Center. And it is my honor to introduce tonight's speakers. But first, please take a moment to turn off or silence any cell phones. And following our second presentation, both speakers will be available to answer your questions as part of a panel discussion. There are two ways you'll be asked or be able to ask questions tonight. The first is to write your question on one of the cards found in the middle of your table. We will collect those cards at the end of each presentation and read them following our second speaker. Or if you prefer, we will also have handheld mics available for you to ask your questions directly. Tonight we will hear from two experts on the topic of peripheral artery disease and limb care and preservation. Our first speaker is Dr. Eanas Yassa. Dr. Yassa is a vascular surgeon with the Spectrum Health Medical Group. She earned her medical degree at Michigan State University, completed her residency at University of Iowa, and completed her fellowship in vascular surgery at Cooper University Hospital in Camden, New Jersey. Please join me in welcoming Dr. Eanas Yassa.
Hi, everyone. Oh, it's working now. Thank you. Hi, everyone. As just introduced, I'm Dr. Yassa. You can call me Eanas. That's my first name. My father is also Dr. Yassa, so whenever people kind of mention or call out Dr. Yassa, I still, even this many years later, look behind me and look for my dad. As mentioned, I went to Michigan State University for medical school. My husband went to the University of Michigan for business school, so we are one of those houses divided. But we moved here to Grand Rapids about a little over 2 years ago. I have a 2-year-old son, and so far we love Grand Rapids. So we're going to talk a little bit about peripheral artery disease. I brought some props as well to pass around so you guys can kind of get an idea or a tactile feel of some of the things that we're talking about. Just before I move too far along, can everyone hear me okay? Is the mic too loud? Okay. Am I speaking too quickly? Okay. Sometimes I speak a little quickly. So if I am, just throw your hand up and say, slow that down, please. All right. So as mentioned, our topic for today is peripheral arterial disease for my portion of the talk. So, we talk about a little bit about what is peripheral arterial disease, and we'll get to that. The first question people always ask me is, why do I have this arterial disease? What did I do? How did I get this? And this is kind of the main risk factors that we know put people at risk for peripheral arterial disease. This is a big one. This smoking. It's very common, almost the #1 risk factor for peripheral arterial disease. It's rare that we have a patient who doesn't have a history of smoking in their background somewhere when we're talking to them about arterial disease. This lovely family photo is meant to indicate that your family history is a big risk factor for peripheral arterial disease. So some people, the rare person who has never smoked, or even people who, try their best and live the best lifestyle, sometimes are still afflicted with a high cholesterol or a tendency in their family tree towards developing peripheral arterial disease. This is meant to represent diabetes, which is a big risk factor for developing peripheral arterial disease. Diabetes causes a lot of changes to the blood vessels. We won't get into all of that today, but suffice it to say it's a big risk factor. And then some of these are certainly a lot of people favorite foods. I like the burger and a piece of fried chicken every once in a while. But diets that are too rich in these saturated and trans fats predispose to obesity, hypertension, high cholesterol, and are a big piece of risk factor for peripheral arterial disease as well. So then back to the original question, what is peripheral arterial disease? So this slide is meant to represent your normal blood flow. So you can see blood vessels, most of places in our body are sort of like pipes. Largely what I tell people and what my family tells people is that I'm just a plumber for the human body. I just work on the pipes. So the pipes, just like the pipes in your bathroom or the pipes in your kitchen, you want them to run clean. And this is kind of the normal blood vessel. The blood vessels we're all born with. My 2-year-old's blood vessels, clean pipes. Unfortunately, because of those risk factors, the smoking, the high cholesterol, the diabetes, the dietary things, plaque can build up in the blood vessels. And that's a multi-step process. There's been the early signs of plaque and cholesterol deposition in blood vessels in people as young as 18. Sometimes even younger than that if they have diets that are very high in fatty foods and high family history. So what happens initially is that a little bit of cholesterol or fat gets under the first layer within the blood vessel, and then progressively builds upon itself. Various kind of cells in our bloodstream that are there to fight inflammation kind of appreciate these changes, this cholesterol buildup inside the blood vessel, as inflammation, so that builds upon it as well. And then eventually, unfortunately, you end up with something like this. This is a piece of plaque that I removed from someone's blood vessel. You can see it kind of, this was removed from a blood vessel in the neck. And you can see the blood vessels kind of got all sorts of clot, and this is all cholesterol. And this little tiny channel here is all that was left for blood flow to go through. This is another picture from an operating room. This is a lot of plaque being removed from a blood vessel. The normal blood vessel edge is right here. All of this stuff on the inside in this little channel, that's all that's left for the blood flow to go through, because the rest of it has been filled up with cholesterol and inflammatory cells that are deposited as a result of all of those things we talked about on that first slide. So I don't mean to gross everyone out, but it's helpful to sometimes have a visual representation of what we're talking about. So now that we have an idea a little bit about what happens to the arteries, what are some symptoms you might have that would indicate to you, maybe I have peripheral arterial disease, or maybe my loved one, my husband, my child, my brother, my sister, my mom, my dad has, my wife, I didn't mean to exclude, has peripheral arterial disease. The most common symptom is actually not up here at all, because the most common symptom for some peripheral arterial disease is no symptoms at all. Sometimes people will have a little bit of peripheral arterial disease in the blood flow to the legs, for example, and they have what we call asymptomatic peripheral arterial disease. And in those situations, as we'll see in a couple of slides, what we focus on is really changing the risk factors, talking to people early about those dietary habits and getting the diabetes under control and putting down the cigarettes to change the course of the disease. The next kind of most common symptom is this first one. This is something we call claudication, which is just a fancy way of saying you have a reproducible pain in a specific muscle group when you walk. So in this, for example, a common complaint that we hear is fatigue or cramping or a Charlie horse in the calf. People will tell me, I can walk, I know exactly, I can walk from my car into Meyer and I can make it halfway through Meyer and I can't walk a single step further. I have a horrible cramp in my leg and it's just, that's it, not going any further. I have to stop, stand still or sit down for 5 to 10 minutes and it goes away. And then I get up and I can walk a little further. I can walk back to the dairy section and do, maybe another 10 minutes of shopping and then I've got to stop. Or, my mailbox is, maybe half a mile down the driveway. I can make it to the mailbox, but I'm not making it back without a 10-minute rest. And it's always a set amount of time. It goes away with a little bit of rest. And it's, without a doubt, every single time you walk, and people would tell me, it gets to the point where I can predict, if I walk one more step, I'm not going to be able to make it. Or if my friend asks me over for dinner and she lives 3 houses down, maybe I've got to tell her I can't make it 3 houses down because I know by 2 houses, I can't walk another step. And for a lot of people, that's really life-limiting. And when it reaches that point that it's limiting your life, that's a point where we want to see you. We want to talk about what can we do to both change the course of your disease, educate you about why this happens potentially, and make things better. The other symptom that we see sometimes is this discomfort that we call rest pain. And that's when the blood flow's gotten so bad that they have pain in their foot primarily all the time. Worse at night, people will say it wakes me up at night and I gotta hang my foot off the side of the bed, or I gotta get up and sort of shake my foot out in order to kind of almost get the blood flow back. If I don't do that, the pain is intolerable. Now this is different. For example, a lot of people sometimes have cramping at night or restless legs where they just kind of need to shift their legs around a lot. This pain is kind of, it's like a vice, people tell me, right around their foot. And unless they hang their foot off the side of the bed or shake it out, it's just not going away. And the last one is the one that we'll hear a lot about today, and one that we see a lot at the Limb Care and Preservation Clinic, which is cuts or sores that don't heal. Those cuts or sores can be the result of something minor, like, one of my patients was kicking the ice off her car in the middle of winter, and kicked it hard enough that she got a significant bruise with a blister on her big toe. Just wouldn't heal. She had some significant arterial disease that she didn't really notice until she had a cut or a wound that wasn't healing. Sometimes, particularly in diabetics, who have peripheral neuropathy, which is numbness in the feet, so they can't really feel, what that results in is, sometimes you're wearing shoes that just don't fit well. I'm a woman, I wear high heels. There's lots of times in my day where I realize I'm wearing the wrong shoes. But, fortunately, I have the sensation in my feet to realize that. And so far, I've not developed any arterial disease. So if I develop a blister from ill-fitting shoes, it will heal. Now, if I have poor diabetes and I can't feel that my shoes are rubbing in the wrong place, and I have poor blood flow, that's a bad combination for developing a cut or a sore or a blister that's just not, unfortunately, going to heal. These last two symptoms, the pain in the foot all the time, and the cuts or sores that don't heal, those are the critical areas of vascular disease, the parts where, if your primary care doctor sees this, they want to get you to someone like myself or to Dr. Hodgson as soon as possible so we can start the evaluation. Part of that evaluation starts with a physical exam. Your primary care doctor will do some of this physical exam and then refer you, like I said, to a specialist. The first part of the physical exam is almost always checking for pulses. There's pulses all over the body, but we check for them specifically when we're talking about peripheral arterial disease, in the groins, behind the knees, and in the feet. So if you have a decrease in pulses, sometimes on both sides, sometimes just on one side, or no pulses that we can feel at all, that can sometimes be a marker that you might have some peripheral arterial disease. A more subtle sign is loss of hair over the lower legs. So for a lot of our patients, and a lot of older men, they notice with age that the hair on their lower legs and calves tends to thin. Sometimes that itself is also a subtle sign of peripheral arterial disease. And the other thing, skin changes, thinning of the skin, shininess of the skin, these two things can really predispose you to developing cuts or sores and ulcers really easily. When your skin is very thin and stretched, it's very easy to, bang your leg against something, the corner of a table. I do that all the time. And then you get a cut. And because you don't have enough blood flow and your skin is a little bit too thin, that cut may have a hard time healing. And then the last one is something that, we see a lot in our office, is kind of these thickened, horny toenails. Not by far and away does everyone who has not nice toenails have peripheral arterial disease, but sometimes that's a subtle sign. So then what we do is after you've been referred to us, we do some testing. So you might come to my office and you might see one of my vascular ultrasonographers. So we have a dedicated team of people who are trained to do just ultrasounds and tests on blood vessels. One of the first tests they do is called an ankle brachial index, which is just a fancy way of saying we blow a blood pressure cuff up on your arm and a blood pressure pressure cuff up around your ankles. In people who have no blood vessel disease, the blood pressure at their ankles, it will be the same as the blood pressure in their arms. So that number, this ratio, is 1. And you can see here when you have normal blood flow and the pipes are nice and clean, it's easy to get the same pressure. But if the blood flow in the legs has been decreased because of a blockage or a narrowing somewhere from cholesterol and plaque buildup, then that number, the blood pressure in the ankles, will be lower. So this number, this ratio, will be less than 1. This is just kind of another way of showing you that. You can see here, this blood vessel is a nice clean pipe, a big tube. It's going to have a normal blood pressure. This blood vessel, there's only this tiny little passageway of blood left to squeak through. So this blood pressure is going to be lower. So here's an example of someone whose blood pressures in their ankles are, these numbers are telling us that the blood pressure they're getting around the ankles is 80, 80 here versus 160 in their right arm. So we take this high number and put the highest number we get in their ankles over that lower number, or the highest number in the arms, excuse me. And then we get these numbers, 0.5, 0.75. So all those numbers are less than 1. And that tells us that somewhere between the heart and the legs, there's a narrowing or a blockage. These ranges, these numbers come in ranges. So we know anything above 0.9, we consider normal. And then when you're in that mild category, the 0.7 to 0.9, those are people who might have no symptoms at all, or their only symptom might be, when I run in the airport, if I'm running a long distance, or really spending all day shopping with my daughter or my wife, that's when I really, get some cramping. Blood flow in this range, the symptoms are mild. In this moderate range, those are the people who tell me, I make it to the mailbox and I've got to stop. And then the severe range, those are the people who have the pain in the foot all the time, or the cuts or the sores that aren't healing, usually. Certainly there are people who will kind of, wave in between these categories, but generally that's what we're looking at. This is just an example of one of those tests. This is one of my patients that had an abnormal test. So just we look at these blood flow numbers, and there's a couple of things that are interesting here. You can see, the waveform that's supposed to kind of just look like a nice wave like this is very irregular on this side. It's not really a nice pulse or a nice kind of regular up and down wave that we would expect to see. And this is interesting because what this test is telling us is that the blood pressures were actually too high, meaning even when my ultrasonographer tried really hard to squeeze down that blood vessel, the blood vessel was, instead of having lots of disease inside it, it was hard like a calcified pipe, or truly like a pipe you might see in your bathroom. They just couldn't, no matter how hard they tried, squeeze the blood vessel close to get a blood pressure. That's something that we commonly see in diabetes. So the numbers might be really high. You get too high of a blood pressure. So again, something that doesn't quite seem like a normal range. It's not in that normal blood pressure at the ankles is the same as blood pressure in the arms. Anything that's away from that normal expectation gives us a tip or screens us that, hey, this person might have peripheral arterial disease. We need to do more of a workup. So then the next step, if you've had one of those screening tests that suggests, yep, you might have some arterial disease, is that we get what's called diagnostic imaging. So this is, this is the blood flow in a normal patient. So this is the blood flow. What happens is that this big blood vessel comes off the heart, and it kind of goes like a candy cane in the chest. And around the level of our belly button in everyone, this blood vessel splits to supply blood flow to both legs. And you can see here, these labels just indicate the names of these blood vessels, but these pipes are nice and wide open. There's any significant narrowings anywhere. And this goes all the way to the groin. This next picture picks up blood flow in the femorals. So starting right here at the hip bones, going down to just below the knees. And again, you can see These pipes are nice and clean. This last picture is blood flow kind of from the knees down. And here the blood flow splits into 3 blood vessels. There's one that comes off and goes down and supplies the top of our foot. This one goes down behind the ankle and primarily supplies the bottom of our foot. And then this one kind of stops and supplies most of the blood flow kind of around the ankle and can sometimes, if one of these other blood vessels has a lot of disease or a blockage, can pick up the job of one of those other ones. So like a lot of places in the body, our blood flow is a little bit redundant. It's the same in the brain, for a lot of our organs. The Creator made us with a little bit of extra, so that if one blood vessel goes down, most of the time people are okay. It's when we see a main pipe, so one of these main pipes has a big blockage, then we've got to do something about it. Because unfortunately, usually, there's not doubles of those. So we'll get a little bit into what pictures look like when they're abnormal. But the first thing we want to talk about is, okay, so say you have a test that screens you positive. And then you go on to diagnostic imaging. And yep, there's a narrowing or a blockage. How do we treat that? So treatment comes in what I call 2 major categories. There's the medicine management, and then there's the invasive management. So the medical management involves medicines. And the medicines are an important piece. When someone comes to see me in my office, what I tell them is treating peripheral arterial disease is a lot like building a table or a chair. If I built you a chair or a table and said, hey, come on and sit down, there's only one leg here. You'd probably look at it and go, I don't want to sit in that chair. Now, if I built you a chair and it only had 2 legs, and you kind of wobbled it a little bit and it seemed unstable, you wouldn't really want to sit in that chair either. But if I built you a nice solid table with 3 legs, or a nice solid table or chair with 3 legs, and you felt it and you said, oh yeah, that feels steady, I'm fine with sitting in that. And that's part of how we have to treat peripheral arterial disease. We have to do all the pieces. So we can't just do the surgery and pay no attention to the medicines. Now, and we also sometimes can't just do the medicines and pay no attention to the surgery. We have to factor in all 3 pieces to build a solid platform to treat the peripheral arterial disease. So, excuse me. We'll talk a little bit about the medicines that are an important piece. Dr. Hodgson will talk a lot about wound care. So particularly if you have a cut or a sore that's not healing, how you take care of that wound, how you make sure it's clean, and how you make sure you're not continuing to put pressure on a place where something's trying to heal is an important piece of treating the symptom of peripheral arterial disease. And then we talk about, well, interventions. There's minimally invasive interventions. That's something like stenting, or treating something with a balloon. Or you may have heard of this rotor-rootering of blood vessels. The medical word for that is atherectomy, where people go in and we shave down the plaque that's in there and kind of rotor-rooter it clean. Those are what we call less invasive treatments. And then treatment can become more invasive, like bypass surgery. Most people have heard of bypass surgery for the heart to get around blocked arteries. We also do bypass surgery in the legs to get around blocked blood vessels. If treatments like a stent or a balloon or a rotor-rooter are just not going to work, or they've already failed once before, then we have to move to the next step. And that next step is sometimes bypass surgery. So, like I mentioned, we've kind of got to have the stable stool. The other piece of why does medical management matter is part of our goal, is to save the limbs. Everyone comes to me and they've been told they have peripheral arterial disease, and their first question is, am I going to lose my leg, doc? And I think, if you have mild peripheral arterial disease, most of the time I can tell you no, that's not something I'm worried about for you. But this other piece is that we have to also work to save your life, because peripheral arterial disease is sometimes a marker of other places in your body where you might have blockages or narrowings in blood vessels. And if I was to say to you, don't worry about it. You don't have any symptoms for this peripheral arterial disease. Go on home, keep on smoking, have 3 burgers for dinner. Don't even worry about it. Don't worry about your diabetes. Just throw your insulin away. You don't have any symptoms. I'm not doing anything, and I'm for sure setting you up for other areas, even if your legs aren't causing you symptoms. for the blood vessel disease around your heart, the blood vessel disease potentially in the blood vessels that feed your brain, to catch up with you at some point. And we want to avoid that as well. So this is kind of, I'm going to try and stay away from big studies and medical literature, but there's a couple of things that I think can really be driven home here. This is a big study in patients who had asymptomatic peripheral arterial disease, meaning they showed up, someone did a test on them, they went to a screening, those numbers, that ankle brachial index number was low, they saw a vascular specialist and said, I don't have any symptoms at all, versus people who had symptomatic peripheral arterial disease. And they had almost 7,000 patients, and they followed them for 5 years. Most of them had, not really a lot of peripheral arterial disease. And then it was about split in the people who had no symptoms and people who had symptoms. And like I said, they followed them for a number of years for big events, things like a heart attack, needing coronary surgery or a heart bypass surgery, needing surgery on the blood flow to the brain, having a stroke, eventually needing surgery on their blood flow. And this is what they found. So this is kind of a, again, I'm going to try and simplify charts like this, but the key is, in this number, this green line, these are the people with really no blood flow. And you can see by 5 years out, most of them had not had anything happen to them. Most of them never had a heart attack, they never had a stroke, they never had any loss of blood flow to their legs requiring any major surgery. They did fine. This group of people, these are the people who, when they were diagnosed with the peripheral arterial disease, had no symptoms. I feel fine, doc. When you follow those people out, by 5 years, probably around, we'll say 85% of them had had nothing happen. But 15% of them had had an event. Even when they had no symptoms from the blood flow in their legs being a problem, they'd had a heart attack, or they'd had a stroke, or they'd had something happen to them that their peripheral arterial disease was maybe an early marker that they were at risk for. And then this last blue line is unfortunately those people who had symptoms related to their arterial disease. And you can see here, by the time we reach 5 years, most of them have had some sort of event. So this, I think, emphasizes that you really need to treat medically, even if you don't have a symptom related to the blood flow problem in your legs. That doesn't mean go home, pick up a pack of cigarettes on the way home and 6 burgers. You still have to talk about what can we do with your lifestyle and your risk factors. This is sort of a complicated chart, but basically what it says is when they grouped them, they subgrouped them by how low those ankle brachial indexes were. Were they in the mild group? Were they in the severe group? Again, this last line is the severe group, and the likelihood by the 5-year point that people in the severe group had not had something, had an event, was really, really low. By the time they reached that 5-year point, people who had that severe peripheral vascular disease, the pain in their foot all the time, or the sore cuts that weren't healing, almost all of them had to have some operation or had had a heart attack or a stroke or something. So then how do we modify those risks? We talked a little bit about putting down the cigarettes, changing your diet. You can't necessarily change your family history, but you can change the other risk factors. If you know you have high blood pressure, getting your blood pressure under control can be key. If you know you have high cholesterol, getting your cholesterol under control, changing your diet, taking some medications. If you know you have diabetes, getting your diabetes under good control. And then this endothelial inflammation, which means that we've started a process in the blood vessels that is irritating to them. They're inflamed. It's sort of the process of if I go outside and, knock on wood, it doesn't happen, but I fall and sprain my ankle. My ankle's going to get really swollen and inflamed because I've done something to annoy it. Similarly, once we start a process of doing something to annoy the blood vessels, there's an inflammation that's going on. We've got to try and stop that inflammation somehow. We can take away the things that are annoying it. I can not put pressure on my ankle. I can not go out and sprain it every day. but I've got to do something else. I've got to treat the inflammation that's already happened. And then, of course, do something to treat the symptoms that you're having now. So part of how we treat the cholesterol or we treat the inflammation is with statins. And this is sometimes a sore point. A lot of people come to my office and say, nope, everyone I know who's ever taken a statin had a big problem. Not taking statins, not interested. And that's fine. I always tell people this isn't the Soviet Union. You can make a decision, but you have to know the facts if you're going to make a decision like that. And the facts are that when we look at thousands of patients who took a cholesterol medicine, 10,000 patients, and compared them to patients who didn't take a cholesterol medicine, when it came to anything like a prior heart attack, they got started on a cholesterol medicine, the likelihood of that happening was better when they, or not happening again, was better when they took a statin. People who'd had a prior peripheral arterial disease, or patients with diabetes, or patients, this CVD means cerebral vascular disease, or problems with the risk of stroke. Everything far and away was better. The likelihood of those things happening again was lower if they took a statin versus the 10,000 patients who didn't. So for those reasons, for a lot of times, if you have some peripheral arterial disease, we'll suggest a medicine like a statin to treat the inflammation and help normalize the cholesterol. So this is kind of, again, like I talked about, the statins do a lot of things. It's not just the cholesterol. Sometimes people will say, my cholesterol is normal. But I'll say, you know what, there's that inflammatory process that we have to treat now. We've got to halt that. We've got to reverse that. So it's not just the cholesterol. We can skip this slide, but basically it's that medicines to control your blood pressure and heart rate are also really important. And then people always ask me about aspirin. Aspirin has been shown in lots of studies, over 300,000 patients in these studies, to decrease, again, the risk of them having heart attacks, strokes, or anything from a blood flow standpoint that ultimately can cause them to die. So unfortunately what we know is when we look at people who just had peripheral arterial disease, who showed up with just peripheral arterial disease versus patients who went to their heart doctor and found out had a symptom of a heart attack, those patients who just had peripheral arterial disease, often, unfortunately, their symptoms were blown off, or that marker was blown off, and they were not treated and managed as well with their medicines and didn't take as good control of their diabetes as when people found out, gosh, I have blood vessel disease in the blood vessels around my heart. So what I tell people when they come to my office is, if you have blood vessel disease in the blood vessels of your legs, I can tell you have blood vessel disease in the blood vessels around your heart. You do. It may not be enough to cause you a symptom right now, but let's not wait until we get there. Let's do something now about this marker, this, notice, this early notice that we've been given. So again, these are kind of, sorry about this unpleasant picture, but this is the kinds of sores when we talk about cuts and sores that aren't healing. In diabetes, the classic changes are that the muscles that supply the toes kind of shorten. People lose sensation in the foot. And then the normal sweating and moisturizing of the skin also goes away. And so people classically develop sores kind of here and in the heel, areas where their shoe might rub or where they're putting pressure. Other situations like this, unfortunately, is when you just have really, really bad blood flow and the blood flow doesn't even make it down to the toes. This person might have initially just banged their toe on something, but the blood flow got so bad that when they just banged their toe on something, had a tiny scrape, there just wasn't enough blood flow to heal it up. So again, the reasons why we worry about when people have those levels of disease is that there's a much higher likelihood when you're at that point where the cut and a sore that's not healing, or pain all the time, that you might actually progress to losing a leg. So we get much more aggressive, certainly, but we still want to treat you when you don't have symptoms or when your pain is only when you walk. Oftentimes, people who have that type of pain, or a cut or sore that doesn't heal, sometimes they'll tell me, no, I've never noticed that I get cramping in my legs when I walk. Sometimes the first sign of their peripheral arterial disease is that cut or a sore that's not healed. So these are some picture examples of blood vessels that we've treated with stents or balloons. Just got a couple of things I want to pass around for you guys so you get an idea of what I'm talking about. You can kind of handle these and pass them around. These are two types of stents. So when I show you a stent, this is a bare metal stent that we would put in the blood flow to someone's legs. And this is a covered stent. So this is a big version of a covered stent. But we might put this in a blood vessel as well. So either one of these, you can just pass them around and then eventually circle back to me. So you can see what I'm talking about when we're saying stents. So in this person, this blood vessel here was completely blocked. No blood flow getting to that side of the leg. And we were able to open it up by putting stents in. Similarly, in this person, if we look here, a narrow in here and no blood flow going to this side of the leg. These are stents with balloons going in, and then you can see the blood flow is nice and wide open afterwards. So in those situations, we're able to fix the blood flow pretty quickly and pretty easily for the patient. It's a lot of work for us, but by putting stents in. This is a picture of an atherectomy. So that's that rotor-rooter. So in this patient, you can see there's a blockage here right through the blood vessel. It's supposed to come down and be a nice pipe, and instead it stops. Now the body's tried to grow a pathway around this blockage. Desperately, the body's kind of gone, oh, no, it's sort of like when you're driving down the 131 and there's construction. Someone sets up a detour. It's not a great detour. It takes twice as long to get where you want to get. But the body's trying to do that. It's trying to build a detour around the blockage. So in this situation, we were able to come through and rotor-rooter clean the blockage. And then you can see now the blood vessel's still a little bit irregular. It doesn't look as great as it would look if stented, but it's certainly cleaned out and the normal blood flow is restored. These are just some other pictures of stents. You can see here the blockage, and now with stenting, the blood flow looks like a nice clean pipe again. Kind of a similar picture of the same thing. Again, you can see there is blood flow at the bottom. So it's not like with this blockage, there's just no blood flow going to the leg. The body's built those detour pathways. But when you have a cut or a sore that's not healing, or pain all the time, or even cramping when you walk, sometimes it's not enough. So if we can improve the blood flow by getting a stent in or opening up the blood flow, then we'll certainly do that. Again, like I said earlier, just the surgery, just putting the stents in, that's not enough. We've got to do the other pieces. We've got to stop the inflammation by stopping smoking. We've got to fix the cholesterol. We've got to correct the diabetes. Otherwise, the stool topples over and the stent doesn't continue to work. This is a complicated patient, and I'm just showing you these pictures to give you an idea of when there might be too much disease to do something like stenting. So this patient, this is the blood flow in the abdomen. This is one of the kidneys. This is a piece of the liver. And this is the blood vessel, and all of the bright white is calcium and plaque that's built up in the blood vessel. So you can see it kind of goes all the way from this artery to the kidney, down, it goes through the blood vessels into both legs. There it is again, and it's even in the blood vessels in the groin. And then down here, it's even in the blood vessels by the knees. So I can't make you the $1 million man or RoboCop and line you with stents from head to toe. That certainly doesn't work. So sometimes we have to do something different. Sometimes stents are not going to be the answer. And in those situations, sorry, this is just another picture of someone who blood flow gone here, and it only shows up again by the ankle. We don't put stents in the blood vessels below the knees. So those are a situation, again, where we have to talk about a bypass. So this is kind of a schematic of bypass surgery, but if you have a blockage that's significant in the blood flow going into the legs, sometimes we do a bypass operation that goes all the way from the blood flow to the kidneys down around the blockages, and we sew it to the blood vessels in both legs. Sometimes we do a bypass operation where we just go around a blockage that's in the blood vessel in the thigh. Sometimes we have to do other fancy things like making new blood flow in pathways where there wasn't blood flow before. Most of the time, if we're doing blood bypasses in the blood flow in the legs, we do it, if we can, with someone's own veins. If people don't have a vein that's usable enough to do a bypass with, then we have to use pieces of plastic tubing. And I just wanted to bring in some plastic tubing so you guys would get an idea of what that looks like. Because people will always tell me, well, I have a rubber hose at home. If I bring it in, can we just clean it up and use that? And we unfortunately can't. But that's an example of a piece of tubing. And then we use this very, very fine suture. And then I always show people these little tiny instruments that we use. So I'll bring this over here so you can take a look as well and then pass it around the room. But this is an example of a piece of tubing that we might use to do a bypass. And then we sew it in with these tiny, tiny blood vessels, the tiny, tiny suture. And we use these very fine instruments. And I wear special magnifying glasses to do that operation.
Yeah, I've seen it lots of times.
And I would be remiss, so that's kind of the end of my peripheral arterial disease talk. Dr. Hodgson might talk to you a little bit about people who have cuts or wounds from poor vein flow, and you might have some pamphlets. I just wanted to touch on that very, very briefly. The veins are responsible for bringing the blood back up. So the arteries bring blood down, and the veins then bring it back up. When the veins aren't working properly, blood can kind of pool down in the legs, and people end up with sores that look like this. There's not a bypass operation I can do to fix that. So that's where careful wound care and being seen somewhere like a limb care and preservation clinic to identify which problem it is, take care of the wounds, treat you properly is a big piece of getting you healed up. So that's the end of my talk. I think I went over a little bit, I'm sorry. But we can get Dr. Hodgson up, and then we can take questions at the end, or how would you like to do that?
Yeah, no, just thank you very much, Dr. Yassa. And next we're going to hear from Dr. Richard Hodgson. Dr. Hodgson is an internal medicine and wound care specialist with Spectrum Health. He also serves as the medical director for Spectrum Health's new limb care and preservation clinic. The clinic uses a multidisciplinary approach with specialists from vascular surgery, wound healing, and hyperbaric medicine to help save limbs and save lives. So please join me in welcoming Dr. Richard Hodgson.
Good evening. Thank you. I'm not going to be quite as verbose as Dr. Yassa, and I'm not going to show ugly pictures because I was told I couldn't show my ugly pictures because they were afraid it might upset people too much, because my pictures are mostly of real problems and not nice diagrams and things like that. So with that in mind, let's see if I know what I'm doing here. I think I do. I started out in internal medicine probably about 25 years ago here in town, and did primary care medicine for about 12 years. During that period of time, I took care of a lot of different types of problems, and one of the issues that we always had was what could we do with folks who presented with some of these problems. If we imagine the diabetic who walks out onto their deck on a nice sunny day and decides they need to sweep off their deck. It's 90 degrees, beautiful, nice day, birds are chirping, they sweep off their deck, they get back in the house, and they realize that they're leaving a blood trail across their kitchen floor. And they look down at their feet, and their feet are blistered. What they've been doing is standing on their deck with the sun beating on it. The deck is probably a lot warmer than 90 degrees because the sun warmed it up, and they burnt the bottoms of their feet because they couldn't feel them. Okay? The number one cause for people with diabetes to get sores is the fact that they don't feel anything with their feet. They develop a peripheral neuropathy. Now I have a problem that is probably multifactorial. Their diabetes isn't controlled well. They might very well have problems with infection. They have a burn on their foot. They might very well have peripheral vascular disease. They need a wound healing specialist. They might need special shoes or something to wear while both of their feet are healing, because you're not going to walk on these burnt feet and expect them to heal. And now, as a primary care physician, I have to figure out, okay, I got to get them to a burn center, probably the vascular surgeon, certainly want to get their diabetes under better control. They might need an infectious disease specialist because of the infection they got from walking around in all the dirt that was on the deck barefooted, and now have burns on the bottoms of their foot. And now I have to try to coordinate all that. Well, imagine if you're not supposed to walk on your feet, that I now have to go to 5 different places. The burn specialist, the vascular specialist. Got a pretty hot mic this evening. Sorry, I'll turn my voice down. Etc. And you have to get to all of those appointments. Probably have to try to help make them with your primary care office. And now I've got to keep going around in circles, trying to do that until my feet are healed. Plus, I might have to go get special tests, or might have to go to the hospital for x-rays, all those sorts of things. So one of the things that we decided to really needed to be done for folks with those types of problems is that they need a one-stop place where they can go and get all of those particular services with one appointment, one place to get their testing, one place to get all the things that they might need to help fix their feet or their legs. So that's where limb care and preservation came in. Diabetes is one of the biggest issues that we see in our office. Grand Rapids has a population of about 200,000 right now. By 2035, it's estimated that we're going to grow by 30 to 50%. So there may be 300,000 patients or people living in Grand Rapids area by 2035. And every year, they estimate that 15% of the population is diabetic right now. By 2035, they're estimating that 40 to 50% of the population that lives anywhere in the United States will be diabetic. At any one time, 15% of that population of diabetics will have a wound on their lower extremities. That will be anywhere between 500 and 4,000 people with open wounds on their feet by 2035 at any one time, requiring all of those services. Of those 15% who get ulcers on their feet, 5 to 10% of them end up with an amputation. So in any one year, if we look at 4,000 people by 2035, and we take 10% of those, it's a lot of amputations. And it's not always one toe or two toes. Sometimes it's half a foot. Sometimes it's an entire leg. Or even once they've had an amputation on one side, they become much more likely, because now we're shifting weight to the other side, which I can't feel, putting more stress and things on the opposite foot, so that they'll end up getting an ulcer there, which can lead to another amputation. And ultimately, because of what Dr. Yassa said, this is a systemic thing. It's not just the feet, it's the whole body. But it's a mortality indicator. Within 5 years, a significant number of those folks who get amputations will die. So it's really critical. If we can turn the dial back, let's go back 10 years in the diabetic's life and educate. Let's talk about making sure that your diabetes is controlled well. Let's get that hemoglobin A1, which is a 3-month average, well below 7, if preferably closest to 5 as we can. Prevent the neuropathy. Get you in the proper fitting shoes. While you may have neuropathy, the number one cause of developing the sore is wrong, poorly corrected, incorrectly fitting shoes. So it's critically important that we try to educate our diabetic population so we may be able to avoid some of the problems we're talking about tonight. Okay? So my first slides are kind of full of statistics, especially about diabetes. because that's a huge population for both Dr. Yassa and myself when it comes to limb care and wound care. Some of this I've already mentioned. I'm not going to go ahead and repeat it all because a lot of it's numbers. The risk of amputation in a diabetic is 10 to 30 times greater than someone who doesn't have that problem. 8 out of 10 non-traumatic amputations, of which 85% follow having a foot ulcer in a diabetic. Here's a little bit of the information about what it means if I have a foot ulcer and I'm a diabetic. 13 to 40% mortality at 1 year after an amputation. Within 5 years, almost 40% of those people who had an amputation will be dead. Kind of sobering data, isn't it? So this brings us back to preventive care. Because once the horse is out of the barn and the barn's burning down, it's really hard for me to put the horse back in the barn. Okay? Once a problem's identified, we really need a team. We need a village, basically, to help take care of these folks. Because it's really complicated. I mentioned some of the specialists. Wound healing, that's me. I'm also hyperbaric medicine. We oftentimes will use hyperbaric medicine to help diabetics with foot ulcers. What is hyperbaric medicine? Hyperbaric medicine is a field of using oxygen under high pressure to help oxygenate tissues that aren't getting adequate blood flow. You do that by putting you in a pressure vessel or a recompression chamber, similar to what a diver would go into if they have decompression illness. Okay? What that does is it really bypasses the red blood cells, which are really just buses that take oxygen around your body and deliver it. We're basically delivering the oxygen in the plasma instead of the red blood cells in a hyperbaric chamber. It allows the blood to get to places where the blood won't flow. I should say oxygen to get where the blood won't flow. And that can help trigger healing in some instances. Okay? We already talked about why you might need a vascular surgeon in these instances. Okay? Endocrinologist, people that specialize in managing diabetes, for those people who don't have the control that they need or have a hard time managing their diabetes. Infectious disease specialists. Unfortunately, many folks with diabetes also have a much higher risk for infection because of the elevated glucose. Their immune system doesn't work normally, their white cells don't work normally, they're not getting blood flow to the area that's injured, so their immune system can't work on that infection well. But we need our infectious disease specialists to help us treat those infections. Okay? Our podiatrists or orthopedic surgeons are there to help us correct deformities. Dr. Yassa mentioned the contraction of the muscles in the diabetic foot. They tend to get hammer toes. They get ulcers on the tips of their toes. They also, because of not feeling things, can start to change the architecture of the foot through different fractures or things that occur because they do things with their foot, like kicking the bedpost as they go by in the morning when they get up to run to the bathroom and don't feel that they kicked the bedpost, broke their foot or something like that, and keep walking on it. Okay? Our orthotic specialist, the person who's going to help me get the proper fitting diabetic shoes or the off-loading boot that I need to protect the ulcer and keep you in a semi-ambulatory state. Because if you imagine the cells that come in to heal being microscopic, and you're really Godzilla stepping on those little tiny cells every time you put your foot down, you can imagine that the cells don't hold up very well and squish and don't work well when they're being walked on every day. Okay? I put in the vascular technician, as Dr. Yassa mentioned. We have the ultrasonographers in the clinic to do those screening tests for us. Okay, and they will do the screening tests both for the arterial system as well as the venous system to help tell us if you have insufficient veins and the blood flowing back up to the heart. Radiologists, they're going to help tell us if there's fractures, infection in the bone. They're also going to help us with some of the advanced studies that Dr. Yassa does to look at CT angiograms, to do the angiograms to help them with the stenting, things of that nature. If you could imagine, I just told you that you can't go to work because you can't be on your foot. You need transportation to get back and forth to various studies. You need resources for your wound, you need your dressings, you need your medications, you need a bunch of things like the orthotic that you need to wear to offload your diabetic foot. So our social workers and care management specialists come in to help you get your arms around this problem. That's one of the things that our nurse navigator also helps us with. And then the hyperbaric oxygen therapy that I mentioned. Okay? So these are some of the services that we have within our multi-specialty limb care clinic. It takes one phone call. We will bring you in, triage the problem with the vascular study, the vascular surgeon, the wound healing specialist, determine what you need, try to put a program together to put things back together.